Dr. Lipscombe received her medical degree from McGill University and her specialty training at the University of Toronto. She's currently an endocrinologist and research scientist at Women's College Hospital in Toronto. At the University of Toronto, she is appointed in both the Departments of Medicine and the Institute for Health Policy Management and Evaluation. She serves as the director of the Centre for Integrated Diabetes Care at Women's College Hospital, where she led the initiation of a program for young adults with type 1 diabetes transitioning to adult care. Dr. Lipscombe has developed a successful research program in diabetes epidemiology and health services, with a particular focus on diabetes in women. She's been fortunate to receive past personnel funding from the Canadian Diabetes Association, first as a postdoctoral fellow and then as a clinician scientist, to study the complex association between diabetes and breast cancer. Currently, she's leading a CDA-funded program to test diabetes prevention programs in women who have had gestational diabetes. Dr. Lipscombe has published over 60 peer-reviewed papers and holds a new investigator award from the Canadian Institutes of Health Research. She's also the proud mother of 3 young children, and in thinking of maternal roles when it comes to Lorraine, I feel like a bit of her research mother because I had the privilege of mentoring her as a graduate student. Please welcome Lorraine.
Thank you very much, Jan, for that wonderful introduction, and thank you to the CDA for inviting me today to speak to you about my research that I've been so lucky to have been able to conduct thanks to CDA funding. Okay, we don't want any feedback. All right. So you've already heard from Jan that I'm going to be speaking to you today about my research that focuses on women with or at risk of type 2 diabetes. And I'd like to start by once again thanking the Canadian Diabetes Association for their generous support of my research over the last 13 years. Without their support, I could not have done any of the work that I'm going to be showing you today. I have been lucky, as you heard, fortunate enough to be funded during my training with a postdoctoral personnel award fellowship under the supervision of Dr. Jan Hux, followed by a clinician scientist award at the beginning of my career. And as well, I've been fortunate enough to have research funding from grants. So the goal of my CDA-funded research has been to address the implications of the type 2 diabetes epidemic in women, and I've had 2 main research areas, as you heard from Jan. The first one explores the relationship between diabetes and breast cancer, and the second one is looking at strategies for diabetes prevention after gestational diabetes. And I'm going to talk to you about these 2 areas today. So, as you all know, diabetes is common both in men and in women. Diabetes affects over 1 million Canadian women. About 90% of cases are type 2, like in the general population. And what is interesting is there's emerging evidence that women are more susceptible to diabetes complications than men, both type 1 and type 2. Women also have unique health issues additional to the fear of complications, and those include, for example, they may have problems with fertility and ability to get pregnant. Once they are pregnant, they are at higher risk of pregnancy complications. We have shown that older women with diabetes are more likely to get hip fractures, and this was an under-recognized risk that now is being looked at quite closely in more research. And what I'm going to talk to you about today, women with diabetes may have a higher risk of breast cancer. Oops, sorry. Okay. So, diabetes and cancer. So there's been evidence emerging over the last 2 decades of a link between diabetes and many types of cancers. And this is largely limited to type 2 diabetes. And my work has focused on looking at the relationship between diabetes and breast cancer being the most common cancer in Canadian women. And I have looked at this largely with the lens doing epidemiologic research, as well as looking at healthcare factors that may be contributing to this association. So how my research into this area has used Ontario healthcare data available to us at the Institute for Clinical Evaluative Sciences in Toronto. And we have available to us anonymized data for 12 million adults, and these data include information on doctor visits, hospital admissions, prescription information for seniors, as well as certain disease registries, such as the Ontario Cancer Registry. We also have available to us the Ontario Diabetes Database, which was actually developed by Dr. Jan Hux in 2002, and this is a registry of the majority of adults in Ontario diagnosed with diabetes, and it's now the largest diabetes registry in the world. So I'm going to talk to you about some of the discoveries that I've made in the relationship between diabetes and breast cancer, first under the supervision of Dr. Hux and later on as a clinician scientist with CDA funding. And so I have a schematic here just to illustrate to you some of the discoveries that we've made. So our research largely focused on women with diabetes, and we focused on postmenopausal women, so older women, and we found a number of things. So the first thing we found is that women with diabetes are at a higher risk of developing breast cancer compared to women who do not have diabetes. We also found that once they develop breast cancer, they're more likely to die from their breast cancer compared to those who don't have diabetes, so higher mortality. Let me just try the pointer here. There, okay. Another interesting observation that we noted was that women with diabetes are actually less likely to get a screening mammogram during any given interval compared to those without diabetes. And that, we've shown, has led to more advanced cancer stage at diagnosis, which can also contribute to their higher mortality. And so this discovery was very surprising to us because we thought, well, women with diabetes are seeing their doctor regularly. So if they are, they should be getting their screening mammograms. Well, in fact, what we realized is that taking care of diabetes takes a lot of time, both for the patient and for the doctor. And this may actually distract from other preventative healthcare issues. And in fact, that is probably what's happening. And so this was a very important finding for us because it has led to a greater awareness about maybe looking at how we deliver diabetes care so that these other issues are not being neglected. We also recently, with a student of mine, actually found that women with diabetes who are treated with metformin, which is one of the most common anti-diabetic agents, may actually have a better survival if they have breast cancer compared to being if they're treated with other diabetes medications. And I'll touch on why that might be in a moment. We also looked at the opposite relationship. So interestingly, not only are women with diabetes more likely to develop breast cancer, but in fact, breast cancer survivors who do not have diabetes are more likely to develop diabetes after they've survived their cancer compared to those who didn't have cancer. So that was also an interesting observation and illustrated to us how complex this relationship is and also that it's bidirectional. Okay. So there are many possible reasons for this association, and in the interest of time, I'm not going to get into all of those reasons, but I will touch on some of the possibilities. So the most common theory that people have put forth regarding why there's a relationship between type 2 diabetes and risk and mortality of breast cancer has to do with shared risk factors between the two conditions. And so, as all of you know, for type 2 diabetes, obesity and lifestyle factors contribute to a higher risk of insulin resistance and diabetes. And this can also directly contribute to a higher risk of breast cancer, as well as indirectly through insulin resistance and early on through elevated insulin secretion. there's evidence to suggest that high insulin secretion actually can promote the onset and progression of certain cancers. And this has been shown for many types of cancers. And in fact, what was very interesting and what led me along this path early on when I was a student looking for a project or a research question was that there was research showing that breast cancer survivors who did not have diabetes had higher poorer prognosis and higher mortality after their breast cancer if they had higher insulin secretion. So that was very interesting and led us to look at, well, what is that? How does that affect breast cancer outcomes for women who have diabetes? There's also, as I've pointed out, healthcare differences that may explain some of the associations that we found. For example, women with diabetes were less likely to get mammograms, which may lead to a poorer prognosis, more advanced stage of diagnosis. And then finally, certain diabetes drugs, the drugs that we use to treat the condition, may actually affect this relationship. And I've shown you that metformin, which actually lowers, which actually lowers insulin resistance and decreases insulin levels, may actually improve breast cancer survival. And in fact, currently there's a randomized controlled trial looking at whether metformin can improve prognosis in breast cancer patients. And conversely, drugs that increase insulin secretion may in fact increase the risk of breast cancer. And there's ongoing research looking at that. So how does this research help us to improve breast cancer survival for our patients who have diabetes? Well, research can inform interventions at the level of prevention, early detection, and treatment. So as I've mentioned, at the level of prevention, if there are shared risk factors related to insulin resistance and hyperinsulinemia, perhaps interventions that target those risk factors might actually help prevent breast cancer. At the level of early detection, I talked to you about how we need to improve breast cancer screening for women with diabetes, and so we may need different models of care to be able to ensure that they get screened appropriately so that we can detect the cancer early and increase their chances of survival. And finally, at the level of treatment, as I've mentioned to you, metformin is being actually looked at as a potential cancer treatment in this population to help improve survival, but there may be other factors as well that could be looked at to help improve outcomes for this population. So to summarize this part of my talk, I've shown you that we were one of the first to show that diabetes and breast cancer more often occur together, that diabetes affects both breast cancer risk and outcomes, and the relationship may go both ways. And our research is helping to find ways to improve breast cancer survival for women with diabetes. And I should mention that this work has also informed research for other cancers, for example, colorectal cancer, prostate cancer, and many other types. So the next part of my talk is to talk about strategies for diabetes prevention after gestational diabetes. And here I focus more on younger women with or at risk for diabetes. And why diabetes in young women? Well, work that I did with Dr. Jan Hux as well when I was working with her showed that although young women have low rates of diabetes, they were the fastest growing group with diabetes, the women aged 20 to 49 in Ontario, when we looked at the increase in the prevalence within a decade. And this is important because this is a group that have a long time to live with diabetes, increasing their risk of complications, as well other issues such as pregnancy and fertility. And in fact, a large part of my practice involves young women. As you heard from Jan, I actually work with young patients with type 1 diabetes who are transitioning from pediatric care, and I see a lot of these young women, and it really underscored for me the importance of optimizing the care for this population. We also I also work with women who have diabetes during pregnancy, both pre-existing diabetes as well as those who develop gestational diabetes. And this, to me, gestational diabetes was an opportunity for us to identify a high-risk group who could be targeted for prevention, because if we're going to stem the type 2 diabetes epidemic, we really have to be looking at ways to prevent the condition, and young women are an important population to target. So, as all of you know, gestational diabetes, or GDM, is a temporary condition of pregnancy that usually resolves after delivery in most cases, but it's been shown that these women have a higher risk of type 2 diabetes in the future. And in fact, data from Ontario has shown that 1 in 5 women who've had GDM are actually diagnosed with type 2 diabetes within 10 years of their delivery. So it is really an opportunity for diabetes prevention. This is a population that are in the clinic. We see them. We've identified them as having a high risk for type 2 diabetes. So we should really be working with them to help lower their future risk of diabetes. Unfortunately, though, and this is very frustrating for me as a clinician, is that few preventative programs actually exist for this population, and there's a real need for them because studies have shown that their preventative behaviors are poor. New mothers have lots of competing demands. It's very hard for them to implement healthy lifestyle changes, and it's not just limited to women with GDM. All new mothers have a difficult time with lifestyle changes. And in fact, a lot of people have tried to implement prevention programs for this population after delivery, but they've failed because women just don't come. And I myself started a program several years ago at Women's College Hospital, and we worked really hard at developing this program, and in 1 year, only 1 woman showed up. So that's when we said we have to go back to the drawing board and look at what are the barriers and needs for this population, because clearly we do need to intervene, but maybe we need to think about how best to engage them. And so we set out to actually survey almost 1,000 women who've had GDM as part of a research study to try to understand what their barriers, preferences, and needs are. And I'm just showing you what you probably already know, is that there are numerous barriers in this population. They cite lack of time, lack of energy, childcare issues. A lot of these women have low social support. They don't have the family and community support that they need to be able to make healthy changes. And many of them are unaware that they are at elevated risk for diabetes. We found very low perception of diabetes risk in our population. Even though they figure, oh, at some time I may get it, a lot of them don't realize that the risk occurs early in the first 10 years. And even if they do know they're at high risk, they're unsure of what changes to make. And so on the good side, women were motivated to want to make changes. They were worried about future risk of diabetes, and they were interested in resources to help them lower their risk. So with that in mind, we developed, thanks to funding from the Canadian Diabetes Association and earlier funding from the Lawson Foundation, we developed a novel, innovative program based on these data to help prevent diabetes in this population. And we called this the Avoiding Diabetes After Pregnancy Trial in Mothers, or ADAPT-M. And thank you. And this would not be possible without funding from the Canadian Diabetes Association, I have to tell you. They were very supportive of this, and we're really grateful to them, because this has been a very ambitious endeavor. In fact, so to develop this program, we had to bring together numerous stakeholders, experts from all different fields, as well as people that can help us implement the program within the community. So eventually, after we had all our consultations, we went to the literature, we were able to develop a novel program that addresses these barriers and is able to engage this population. So first of all, it involves home-based coaching instead of them having to leave their home by telephone with frequent follow-up. The program is being delivered by diabetes educators in the community. So diabetes educators are already trained in counseling and diabetes prevention, and we offer them additional counseling for this population and in exercise counseling specifically by our cardiac rehabilitation experts. We provide evidence-based education on healthy diet and physical activity with an understanding of the specific needs of new mothers. And we use evidence-based counseling approaches such as goal setting and action planning to help women slowly advance toward their ultimate goal. We are conducting a research study funded by the Canadian Diabetes Association to test this program, to see if it actually can successfully engage this population and successfully reduce their diabetes risk factors. So women with gestational diabetes are being recruited from 4 hospitals during their pregnancy, and once we recruit them, then once they deliver, we assign them randomly to either a 6-month lifestyle program, our 6-month lifestyle program, or to usual care, which consists of one meeting with a counselor, a diabetes educator. The 6-month program involves frequent follow-up by telephone. And then at the end of the program, we're going to test everyone to see if they're, for a number of diabetes risk factors, to see if they've improved over time. And importantly, we are also inviting their partners to be tested before and after the program. The partners are not receiving the intervention, but they are going to be tested because for 2 reasons. One is we want to engage the partners to help increase the support for the mothers so that they are not alone doing this. And secondly, we want to see to what extent does this program not only help the moms, but actually help other family members. So, there are numerous potential impacts that our ADAPT-M might have if once we complete the research. So if we are successful, then we can implement a diabetes prevention program for high-risk young women that, one, is sustainable because we are using existing diabetes education resources in the community. We're involving telephone follow-up, so it's an efficient model of care. We are doing our best to accommodate barriers through home and community-based approach and through an individualized approach that addresses needs. We hope it'll not only lower the risk of diabetes in the moms without using medications, but may benefit the entire families. So to finish off, I hope I've convinced you that my funding from the Canadian Diabetes Association has led to important discoveries about diabetes for both younger and older women, and this research is helping to improve the lives of women affected by type 2 diabetes. Thank you very much. Oh.